Amanda, I appreciate that. And so happy to be here and see everyone. Thanks for making some time today for this important topic. A little agenda for you to see here. This is what we're going to cover, how to identify and treat eating disorders within college students, supporting students in their recovery, getting back to campus or leaving campus if they need to. And then Carrie's going to cover some case examples and navigating that return to campus. So we hope you enjoy this overview. You can go ahead and flip to the next slide for me. So what I want to make sure is clear, since I know some of you probably know eating disorders very well, and maybe some of you are not as familiar, is that we are very likely to see eating disorders at times of transition in life. And so the first huge time of transition for us all is generally puberty, but usually the next one following that is college. Beyond that, we're likely to see issues potentially develop sometimes as somebody might begin a marriage relationship or a partnership, beginning parenthood, maybe when someone becomes an empty nester, or maybe when there's like a global pandemic and everyone has to adjust their whole lifestyle. These are all important times of transition and change for individuals. And that's when we are really watching and trying to be careful to support individuals who may be at risk or who may be struggling. Sometimes with that, people can tell me, uh-oh, does that mean if my loved one recovers and gets better that they're going to relapse every time there's a transition? And I would say, no, not necessarily, but it's just something to be really sensitive to and aware of as you move forward in life in your recovery. Next slide, please. So when we think about college students with eating disorders or with disordered eating, a couple things that are unique in terms of the transition to college is that oftentimes they are moving into having to take full accountability for their food and their meals. They may have either been in treatment or they may have received some outpatient support and support from you as a family in terms of their meals. And so getting to a campus and having to eat in a cafeteria or order in or potentially even cook and prepare your own meals and snacks is usually a very big transition. So we can see students go a multitude of ways. Sometimes students that are anxious and uncertain will really move into a realm of rigidity, looking for diets or external sources for food advice and for guidance. And sometimes we can see students go to the opposite end of the spectrum and really feel a little bit chaotic, feel like they're overeating, feel like they're eating at strange times of the day and in weird quantities, sort of like a chaos sort of model. So we can see things happen across the board with that. When there's no parent or loved one there to kind of bounce ideas off of, they're oftentimes going to look for peers for support, and their peers may be struggling as well. And so that sometimes can be a challenge too. Sometimes as well, students may, as they're comparing with other students, if they have a roommate that becomes a vegan and they're newly in their recovery, that can be something that might spark an interest in them, especially if they're trying to fit in and connect with other people. Food as an identity or disordered eating as an identity and a way to connect with people can be something that comes up. And then we see in terms of self-care, in terms of an individual's relationship with exercise, that again can move across the spectrum. Sometimes depending on a campus, some campuses are very large and transportation might be limited. And so students find themselves walking and exercising maybe a lot more than they might have when they were in high school. And so being mindful of potentially needing to eat more food in order to compensate for doing more exercise and movement in their life is something that can come up too. Next slide, please. So when we are working with college students, and if you are working with them as well, one of the things that we look for is how can we thoroughly assess and get a good picture of what's actually going on. I work for Monte Nido and affiliates right now, but I actually started my career within a college counseling center, and I would see anybody on campus that walked through the therapy office doors, and I would ask every client that I met with, why don't you tell me a little bit about your relationship with food? Even if the client had no indication on their initial paperwork that they had any issues with food, I asked them that question. And that question was really eye-opening. I oftentimes got quite a lot of information from them just on how they responded to that, which would lead me to do some follow-up, right? I would want to look at specific information around, has there been a huge change in weight loss or gain? Are there any food rules or food restrictions going on with them? Do I need to send for any follow-up medically in terms of ruling out if there's something else contributing to what's going on with their weight? Is there potentially undiagnosed PCOS or some issue with the GI tract that they need to get figured out so that we can rule that out? I want to get some more information as well on what's going on with them nutritionally, what's happening emotionally and psychologically, so that I can understand what potential role is the eating disorder or the disordered eating playing in their life. Oftentimes it's a coping skill that's in place for a reason. And so how can I figure out with them what that is before I'm asking them to change their behaviors? Things that I like to pay attention to in assessment are any underlying familial, psychological, or societal influences potentially on their weight and shape. That might also include their participation in any sports activities. There's obviously some sport participation that might put a student more at risk if they're in the cheer squad, if they're on the crew team, if they're a wrestler. Those are sports traditionally that have higher percentages of eating disorder. So I might ask some specific questions around that as well. And then lastly, making sure I get some medical information for anyone I'm concerned about. And so seeing if I can get recent labs, vitals, potentially an EKG, just to see that I can get a full picture and really understand what's going on with them. Next slide, please. When we're talking about a college student, treatment is sometimes really difficult to do when they're on a campus. They have a lot going on. And so if they're interfacing with the college in particular or university, the college and university might just be assessing them and potentially referring them to a higher level of care, which we're going to talk about in a future slide. And so oftentimes, referring might include making sure that we get a multidisciplinary team on board, either on or off campus. And that would obviously be a therapist and a dietitian, but also that medical doctor, potentially a psychiatrist, and maybe there's some other individuals that might be pulled in as well, a physical therapist, or a specialty medical doctor that might need to help. And so we're looking at making sure that we have a full team assembled that can help somebody that may need it. We also might be looking at pulling in family. And so figuring out, are there individuals within the family that can be particularly helpful to this student? Can we have more support? Do they need to, especially in this day and age with COVID, there's been one advantage has been anyone that's struggling on a campus might be able to actually go home, get support from the family, and do classes remotely. And so just looking at pulling in the family, even for kids that are 18 and up, to make sure that we have enough support in place. And then lastly, figuring out if there needs to be a leave of absence. That might be something that the family and the treatment team have to talk with the student about and figure out how to get a leave of absence in place. A lot of schools and universities in the last several years have done better at flagging students. Some students might not have a choice. If they are caught on campus binging and purging in dangerous locations, they might be asked to take a leave of absence that is not a choice. They may be required to seek some treatment. And then once they're cleared from their treatment, they might be invited back at that point. Oftentimes partnering with the universities and figuring out what's necessary to have a leave of absence take place, and then what might be required for the student to be able to readmit. Next slide. So within that, I think it's really important to understand the different levels of care that exist for eating disorders. The American Psychiatric Association has amazing guidelines that much of the field of eating disorders look at as the gold standard in terms of level of care criteria. So if you're interested in that, I would highly recommend looking at those. But basically what we're looking at in terms of the options for levels of care are, we always start with the least restrictive possible, which would be outpatient. That would usually be individual therapy, group therapy, and then that multidisciplinary team that we talked about. Sometimes at a university, they might offer that individual therapy. Most universities these days will offer therapy groups, sometimes even a specialty group for eating disorders. The benefits of those groups is that they're usually free. And so figuring out if you can tap into resources at the university level that would be free is amazing. Oftentimes, universities and colleges right now are offering really limited and short-term therapy, so they're likely to make a referral to an outpatient provider that we would want to get into place for a student that's just needing that level of care. The next up from that would be an IOP, or an intensive outpatient program. That would usually be about 3 hours a day, usually somewhere from 3 to 5 days a week. And some of those programs have transitional living like the dorm, or supportive housing that can be in place for students that are at that level of care. The benefit with an IOP is that you're usually getting at least one meal while you're in programming that's supported, which is really helpful for individuals. The step up from that would be partial hospitalization, which is usually about 6 or more hours a day, anywhere from 5 to 7 days a week. Again, usually there's supportive housing that might be an option in some programs with that. Individuals that are attending that program are usually getting about 2 meals and some snacks supported, so it's a little bit more. And then the step up from that would be residential treatment, which would be 24 hours a day. Oftentimes individuals are living in a supported home-like environment where they're supported like with staff. All their meals and snacks are accounted for. And if that's not enough, there's always the option of an inpatient stay within a hospital. Usually that would be if somebody is at a high acuity in terms of their medical stability, because hospital stays tend to be short, usually a couple of days, but longer if necessary and deemed by the medical team. Usually we're looking to start at the lowest level of care that's required and step up as needed. And then if someone's at a certain level of care, we would ask that they step down within the levels, just so that we make sure we're providing enough support. If you're a student, it's really hard to be a student in residential. Sometimes students will be able to potentially finish some coursework that they had started, like this time of year in particular, as the semester is ending. Sometimes students will leave a university earlier and maybe have an extended period of time to finish out their work. Same thing in the fall. They might delay and start, or start school and then be able to finish. But usually when someone's in residential or partial, they're usually not actively a student. And so I think that's important to keep in mind too. Next slide. What can colleges do to help treat and prevent eating disorders? This is information from the Multi-Service Eating Disorder Association, which is out of Massachusetts. It's a great organization of professionals, and they have so many colleges and universities in Boston that they asked around. And this is what we got out of that research, is that they ask that there are body image and eating disorder support groups on campuses. Sometimes these are run by students, sometimes by faculty. They asked that there was assistance in education, prevention, and outreach on campus. That is usually actively happening at most universities. There is a body image awareness or eating disorder awareness week, usually in February and March annually, that most campuses will participate in. And oftentimes colleges and universities these days are trying to have some sort of programming and support around body positivity and healthy eating on a campus at all times, just for prevention. Most campuses these days are trying to promote healthy food choices and options in cafeterias. That can be helpful and not helpful. A lot of universities these days are required to also provide caloric information depending on who they use for their meal service. So sometimes that can be difficult, but I know that they're trying to do that. There should also be on-campus dietitians that can provide free support in addition to those counseling services that we talked about. And then a major thing that we're hopeful that universities can help with is disproving the freshman 15 myth. And if you want to switch to the next slide, I talk about that a little bit more on this next slide. I'm sure most of you have heard of the freshman 15. It's a bit of a myth. I think it's important to talk about it in that way. I know people still talk about it when individuals are going away to school. And what we found is that just because you're a freshman in college, it does not mean that you're automatically going to gain weight. It does not automatically mean that you're going to gain 15 pounds. There's a couple things at play here. If you're a freshman in college, you might still be going through puberty. And when you're going through puberty, especially at the tail end, it might be that you're still potentially gaining a few pounds as a result of that huge developmental change that your body is going through. So a little bit of weight gain, I think, can be normalized in this process. The other thing that's happening is what we talked about in the beginning. Students are struggling to figure out how to manage their own food, potentially for the first time in their life. So sometimes there can be slight weight gain or loss associated with being in college and getting used to eating. And then I think sometimes students will engage in maybe eating different types of foods, maybe eating more than they have or less than they have in the past. And then we have to add in potentially drinking, using other substances, things like that can sometimes lead to weight gain or loss again. But what's important is to make sure that we're talking about this, not as a scary thing, but just something to be mindful about for students to not be afraid of it. What we know from our research is that freshmen that are concerned about gaining 15 pounds are much more likely to have poor body image and increased anxiety about their food choices. If you have poor body image and increased anxiety about your food choices, you're more likely to go on a diet. And we know that about 20 to 35% of individuals that go on a diet are at a much higher risk of developing an eating disorder. So keeping the anxiety down, understanding, just be mindful and calm about what's going on and seek help if you need it. And then my last slide, I think, almost my last slide before I hand it over to Carrie, is things to think about when you're starting or returning to college. Really, again, making sure that you're stepping down through appropriate levels of care, thinking about if you were on a scholarship or a work study, reestablishing that if you need to, making sure that you have signed releases so that your treatment team, your family, everybody can stay in touch, and setting up a plan for making sure you have a realistic load of courses that you're going to take if you're getting back to campus, that you have housing and emotional support that's in place, and potentially that you have a treatment contract in place. And if you want to go to the next slide, I think we talk about that as well. So some recovery contract guidelines, oftentimes if I'm working with someone in outpatient therapy, I'll say to the client and the family, let's get a contract together so that we're all in agreement about what you're going to do when you get back to campus. And so that might be, you've got to go to all of your sessions or groups that you've agreed to. You've got to sign releases. You have to gain or maintain the weight that's recommended by your team. You have to abstain from any eating disordered behaviors. I think you get the sense, right? If we want to make sure that we create a contract that's clear, that's not too rigid, but that it helps make sure that we're all on the same page about what's expected for a student to stay on campus. And if you want to go to the next slide, I think the overall big picture that we want to be thinking about are these necessary domains of recovery. Someone struggling from an eating disorder, we want to make sure that we have their medical and their psychiatric care stabilized. Their weight should be stable. We should treat any co-occurring conditions that are there. Psychologically, we want to make sure that they're stabilized. Nutritionally, they need to be doing okay. They need to have flexibility. They need to be able to manage a meal plan independently. Relationally, we want to make sure that they're effective socially and within their relationships. And then we want to make sure, again, that there's a team in place. I mention these domains because sometimes individuals will say, well, my weight is stable, and so I should be allowed to kind of go back to school and everything else should be good. But if we haven't addressed your obsessive compulsive disorder, or if you're still incredibly depressed and passively suicidal, just because your weight's okay doesn't mean you're clear to go back. We need to make sure that all these domains are functioning well before you get back into that place. So that's my snippet. I think I'm going to hand it over to Carrie now, who's going to give you a little bit more specific about some case examples that she's worked with.
Thank you, Dr. Coffin. Yes. Meredith, if you want to go to the middle slide, I'll just give an overview of what I'm planning to talk a little bit about. So I'm going to kind of play off of what Dr. Coffin talked about to give you guys a case example in which I was actually on the team. And this is an example of a client who started in college. It's a very timely example because she started in college when COVID had just hit and ended up coming to treatment with us. And we're now focusing on getting her back into school. So I'll just kind of put what Dr. Coffin was talking about to a real world example, talk a little bit about a COVID informed lens on getting clients back to school. And in addition, silver linings from the past year in terms of some things and some tools we've picked up since COVID has hit that we can use to arm our clients with more confidence and more skills to lead to a smoother transition. Next slide. So starting with the case example, I'll call this client Lori. She is a 19-year-old female. She was already diagnosed when she came to us with anxiety, depression. She actually had recently been diagnosed with bipolar disorder, so a bit of a kind of dual diagnosis situation. And it wasn't until she came to us that we gave the diagnosis of anorexia. But what happened was she had been in her first semester in college, but at home. So basically college from her bedroom. And it was her first semester. So already a lot of stressors there. And the eating disorder was identified by her mom, who she lived with, noticing significant drop in weight and a lot of isolation in her room. Got her to go see a therapist, and the therapist said, saw all these red flags and referred her to a higher level of care. So that's when she came to us. And the first thing we did, I actually did the assessment with her myself on the phone. And she was very new she hadn't been in eating disorder treatment before. So just getting a handle on kind of what was going on with her was the first step in terms of the eating disorder and everything else going on in her life to make sure that we touched on all the points. And so we identified that we needed to figure out the underlying issues of the eating disorder, the triggers that had occurred in that first semester and in her home environment that exacerbated the eating disorder behaviors, what had been going on with her weight and getting that back to a medically stable level, and increasing her tools and skills for emotion regulation, which it was clear she was struggling with, especially with bipolar diagnosis and unmedicated. That was making everything a lot more difficult for her. And then finally getting her confident to return to school. Next slide, Meredith. The first thing we did was try to identify the root of the eating disorder. So just going to focus clinically a little bit here, and then we'll go into kind of like the path of how we got her back on track to school. So understanding the triggers and the vulnerability factors is the first place to start before we figure out when she's in the treatment setting, in terms of level of care, in terms of what other providers we need to set her up with, what kind of additional support she needs. We have to figure that out. And not Melissa, Dr. Coffin spoke to a lot of the kind of college age specific challenges that come up. So for Lori, there were a few here. So low self-esteem she had always struggled with throughout school, but especially in college. That's kind of that transition phase where you're trying to find your ground. You have like the space to kind of come to terms with a new identity, like as an adult, and as you try to find your footing socially. And that is so much harder with COVID because there's no social opportunities, or maybe there are some virtual ones, but not the same as a normal college campus. So her self-esteem was actually diminishing. She wasn't able to take advantage of social opportunities to strengthen that. And that led to isolation and restriction of food to cope with her feelings. Paired with that was family challenges. She had a difficult relationship with her mother. And college is usually that time where young adults are like, yay, I get to leave the nest and find myself. And this is more, I'm actually like in a lockdown situation with my family, which has caused the most challenges for me. So that was an additional stressor. Then we had just the fact that she's in her room with not a lot to do, the lack of structure. And then finally, Dr. Coffin talked to this specifically, but thinness as kind of an identity really applied to her. She was a petite person, had always been identified as kind of like the small little girl. And she kind of like dug into that to say, okay, I can be good at this. I can be good at being the little person, like the small person. And so then the restriction really took a turn for the more severe. she wasn't feeling effective in college. She wasn't feeling smart, but she at least could be the thin one, and probably communicate a bit how much she was struggling with her body size, since that's the external way we can kind of communicate what is difficult for us. And her mom was more likely to see she was struggling if she was restricting. So we had all of that, and we knew that with the level of kind of weight loss and depression she was dealing with, she needed a pretty high level of care. So we assessed that she would be best suited to be in a PHP setting, and I'm going to talk more about that in the next slide. And we were going to have to work around her fears of weight gain, which is going to probably be one of the toughest parts, reducing her isolation, helping her be more honest with herself and lean on others for support, family work, and just getting like supports in place. Next slide, Meredith. So logistically speaking, I think of it as kind of 3 phases. We have phase 1, which is what I just talked a little bit about, kind of assessment. Maybe this is when the client's coming out of school if they need to, not all of the time will they need to, but since we're not in a college, we're seeing the clients who have come out. So coming out of college, getting ingrained in treatment at a higher level usually, and then stepping down, those kind of step down phases that Dr. Coffin was talking about, where we have phase 2 is maybe going down to an IOP level where we're doing less treatment and we're kind of like bolstering the other aspects of life to help increase independence. And then all the way to phase 3 would be getting them back into school. So starting with phase 1 with Lori, we decided it would be ideal to have her living in a supported apartment away from mom, so she could kind of like strengthen those muscles of independence. We wanted to set her up with a lot of structure, and our PHP is going to be different than an eating disorder focused, completely eating disorder focused or specialized treatment center where everything is around the eating disorder. But for us, we had kind of a mix of eating disorder related programming and depression, anxiety, and kind of like life coaching was a part of that PHP. So it was probably half meal groups and meal and body and food groups. And then the other ones were more life skills groups. We set her up with individual coaching that would be working on things like grocery shopping, logging her meals. We had a dietitian doing her blind weigh-ins and working with her around food fears. And then we obviously brought in a psychiatrist because there were a lot of med changes going on. So we're kind of handling and hitting all of the different points: medical, nutrition, psychological, family, and getting ready for eventual discharge. So she was really motivated. She actually really wanted to recover and was like 90% confident that she could, which is not where a lot of clients are when they're starting out with an eating disorder. So it's kind of an ideal case, but she pretty quickly latched on to using her tools, and we were able to bring her to an IOP step down. And in that time zone, we had her doing reduced treatment, but we kept all the 5 touch points that I was talking about of medical, psychological, nutrition, but just at a lower level, and see how that was. And we had her start taking a non-matriculating college course, just one, to see how that was. That's kind of a nice thing that you can try. In New York, there's lots of options for it. And now that there's virtual campuses, there's a lot more options for it. But that can be a really helpful way to test the waters before throwing someone back into a full course load. And then she's going to get a summer job too, part-time. So just seeing, can I handle this while being independent? And she's doing a great job so far. So phase 3 is for this client in the future, but typically this is when we're thinking about how they're going to return to school and in what capacity. So do we think that a full course load is the right thing? Do we think a traditional college campus is the right thing? Somebody who leaves a college doesn't necessarily have to go back to that same college or that same setting. Sometimes it can be actually quite activating to go back to the place where the eating disorder may have began or been exacerbated. So being open to thinking about other options and non-traditional options, and really working with the client on like, what are your goals, and not necessarily the pressures you're used to having of like, you've got to go to the top school and do 5 classes and do all this stuff, but like, could you do a part-time job and a course, or could you do like a more independent campus? Like this client's going to go to Hunter. It's a little different than a traditional college campus. So that's one thing we decided with her, was to switch the environment. And then as Dr. Coffin was talking about with the contract, with her, I don't think we need to call it a contract, but we do want to, sometimes the word contract is scary for people. Sometimes it's really necessary. For her, it's more of an agreement or like a goal, a page of kind of goals that we have in mind for her. And for her, those are consistent meals, weekly sessions with the dietitian still, weekly groups, staying with her therapist, and, monthly check-ins with psychiatrist, and to get labs to make sure that everything is good medically. So she'll also be able to engage with us virtually, which is really nice to help ease the transition. And on the next slide, I'll get more into some of the COVID related broader supports. So if we zoom out a little bit from that case, and again, Dr. Coffin touched on some of this stuff, so I might skip over a little bit, but I think of there basically being like on-campus supports and the off-campus supports, both really important to think about to support a healthy return to college. So on campus would be, as she was saying, researching the options at the college. Is there there's always a mental health center basically, but is there anybody who's trained in eating disorders there? Are there close to campus resources? Sometimes there'll be like a treatment center close to campus that offers an outpatient group that you can join even if you're not in treatment. Maybe like an EDA, Eating Disorders Anonymous, or an online group given COVID. And another on-campus thing is just creating a plan for on-campus if challenges arise. How are you going to respond and react, and having ideas in place. Then off-campus is more like, what is the family doing to help support? How can we psychoeducate family or maybe close friends or whoever's involved to notice if things aren't going great and help that client find support. Also, coming home for breaks. I know that hasn't happened for the last year. They've already been home, but that transition of like coming back to home and home being a hard place sometimes, it's important to think about like what tools the client might need over winter breaks or fall breaks or any breaks, summer as well. So a lot of planning ahead. Supporting the family to understand what red flags to look out for and if relapse or any kind of lapse were to occur, because we know recovery is really bumpy. It's likely there's going to be lapses, like not to react reactively and how to respond and support the client to hopefully be able to stay in school, or if not, like what are the necessary steps. Because just arming the whole family with information is really helpful to reduce the anxiety of going back to school. And then determining any in-home supports or like in-dorm supports as well, whether it's like grocery shopping, meal supports. There are some companies that do virtual meal supports, in-person meal supports at colleges. So that can be a really helpful thing as well. Next slide. So specifically with COVID, just taking a look at the different options that we're likely to see moving forward. A lot of campuses, most I think are still virtual. There are some hybrids, but very few are fully in person. So with virtual campuses, some of the things to look out for with COVID is, again, this lack of social interaction, usually leading to lack of connection. A lot of our clients who are struggling with eating disorders are already insecure about social relationships. So that's going to exacerbate those and kind of increase like cyclical thinking and negative thinking that might promote engagement in eating disorder behavior. There's heightened isolation. That's like basically a perfect storm for hidden food behaviors. If you're virtual, if you're living alone, there's no roommate, there's no dorm, there's no RA, like binging and purging, restricting is much more easy to do without anybody noticing. The lack of structure, it's kind of this mixture of like, if you're at home, there's no structure, so there's no reminders to eat. At the same time, you have 24/7 access to the kitchen, to food, to anything you want, to kind of use as a distractor. So there's a lot of challenges there. And I think I showed with this case how you can kind of incorporate some skills, but just to be mindful of those. And even if we're hybrid or in person, now that we've done a year of virtual, it's another transition now going back to that. So even, all of us who may not relate to having an eating disorder, but to the fact of like, it's weird to go back in person. It's weird to know, like, what to say, what to do. That's going to be showing up for our clients too. So there's probably going to be some fear there about what it's going to be like to re-engage socially, especially for those with social anxiety. And then another thing that happens a lot is if clients have come out of college, they might be a year behind. So they might not be going back to the same cohort of friends, which is going to be difficult to build new connections. So just keeping in mind, like, they're not going to the exact context that they came out of. If they're going from isolation to having to plan their meals and at the same time, be more spontaneous around food, because when you have more friends at college, if you're in person, they're like, oh, let's go to the dining hall now. Let's do this now. Let's go out to eat. Like, that might be difficult if you've become used to a very structured plan. So I know this is probably sounding like a lot of things to consider, but they're all manageable, but just important to know. All right, Meredith, next slide. So yeah, there have been some positives in terms of, or some silver linings in terms of things we have learned. And I think this is a helpful thing. I was just in a group earlier today reminding a client of, like, things are really tough, and like, you've survived, like, you've picked up new skills, you've learned a lot about yourself in this year. So helping our clients figure out, what have you learned that we can take with you? And kind of supporting their confidence that they can manage this is really helpful. So we've had this virtual option, which has allowed us to do, first of all, things like this roundtable, right? Like, connect more with other providers. And for a client, that means connecting more easily to their providers. More schedule flexibility. There's no, commuting time for things. So there's more schedule flexibility in our client schedules and provider schedules, which is a positive. We can increase the continuity of care more easily, because a lot of times they can stay engaged. A client can stay engaged with a past provider, or, for example, with the dorm now, Lori could stay engaged with a therapist as she transitions to maybe an on-campus therapist, which is really a big positive thing. And in terms of what our clients have learned, they've learned to adopt coping skills for boredom that don't involve food, hopefully, being creative around social interactions and getting used to different ways of interacting socially, prioritizing how to build a schedule for themselves and stay sane amidst kind of this chaos. And so we want to help them bring that back to the school setting. Next slide. So tying everything together, Dr. Coffin touched on these domains, but I just want to kind of bring it back to this, because this is kind of, if you leave with one thing, just having these kind of 5 domains in your mind as, let me make sure I have thought of all these 5 areas of support and make sure there's a touch point in each one. So there's the psychological, which would be, are they getting individual therapy, group therapy? Are they getting skills? Nutritionally, are they getting the support they need from a dietitian and an eating disorder informed dietitian, which is, a different thing than just a general dietitian or nutritionist. So that's something I didn't cover, but really important to think about. Med and psychiatric support, and again, a doctor or a psychiatrist who's familiar with eating disorders. Actually, more often than not, with doctors, there might not be as much education around how to navigate weigh-ins and talking about labs and health with a client who has an eating disorder. So making sure that you get the right kind of referral there. Relational supports, meaning like social supports, family supports, and then discharge planning. So making sure that the whole transition is smooth. And even if it's not smooth and somebody has to step back up, like following the clinical necessary recommendations, that if somebody needs to step back up, knowing that that's okay and they can do that, but ultimately having your eye on how to get them out of treatment. And if we can kind of keep that in mind with some of the COVID impacts, or hopefully soon not COVID impacts, then we can allow for a really strong recovery. And that's it for me. So I'm really excited to hear from you guys, any questions, and have a little discussion.
Thank you both so much for that. Such an important topic. I wanted to see if anybody in the audience had any questions, comments, hear a little bit about what you all are seeing with this particular age group of clients, college students and eating disorders in your practices or organizations, and sort of open this up a little bit. You know, one thing that Dr. Coffin, that you started, I think it was one of the first things that you said actually in your portion of the presentation, was that transitions are hard. And they're hard even in the best of times. And being a college student, even in the best of times, is hard. And you put COVID and all of the transitions that come along with coronavirus on top of the natural transition of going to college. And you're really creating such a perfect storm for a college student. I remember, I think it was my first day of class in my master's program, and I was sitting in human behavior in the social environment one. And our professor, one of the first things that she said was, she didn't even ask, she instructed us all to take a piece of jewelry or our watches that we typically wear on a daily basis, take them off and put them on the opposite hand. So I took my watch off that I always wear on this hand, and I put it on my other wrist. And I immediately felt uncomfortable. Like I wanted to put the watch back where it belonged, because it doesn't belong on my right hand, it belongs on my left hand. And the whole purpose of the exercise was really to show how even just the smallest little changes can be extraordinarily uncomfortable, and that change and transition are difficult. We are creatures of habit, and when we have to change what we're doing on a day-to-day basis, it produces anxiety and stress. And if changing my watch made me that anxious, you know, what's it like to do some of these other transitions that we're asking young people to do? So I just, you know, I loved that that's the context that you started the presentation with, because I think a lot of families do ask, you know, well, the end goal is with a lot of these families with college age students is to get them back into school, and then trying to educate them on, you know, what that means, and that, you know, sometimes people, you know, slip a little bit when they transition, and how can we sort of mitigate against the consequences of that slippage, and how can we normalize it and plan for it, I think is just so important to the healing process. So I guess my question is, when we add COVID on top of this, you know, what do you guys all think? And Dr. Coffin, Carrie, you can certainly chime in on this, but you know, what are our takeaways from this time? What have we learned as treatment providers? What can we do moving forward to help these vulnerable clients in these vulnerable times?
Yeah, I think that's such a great point, Amanda. It makes me think of, you all probably know the term double depression, right? That somebody can be in a depressed state, but then have something situationally happen that's difficult. And so they can wind up in sort of a deeper depressive episode. And I feel like COVID has created sort of a doubly stressful transition for so many people leaving high school, starting college, starting another year of school, because it's already hard to transition or to change your watch from your wrist, but then throw a culture of uncertainty and confusion and fear around the pandemic. And yeah, I think it makes it doubly difficult. And I don't think we're out of the woods yet. I think I work a lot with college students. And I think what I'm noticing is also these kids are also starting to lose perspective as in terms of what a normal experience might be. There's just such a loss in social connection and support, and what it's like to eat meals with other people and connect and talk with other people and take a class and sit next to someone so that you can connect around that. I think it's just making it really difficult right now.
Yeah, to add to that a little bit, one thing that I've noticed that I think is helpful is the difference in like this thing being COVID is that we're all going through it. So if we can help our clients come out of their shell a little bit to share their experience with others, group therapy is really helpful. I feel like in this setting, this client, Lori, actually created her own like peer process group here to talk with other clients about it, which was kind of shocking for somebody who has social anxiety and like was new to treatment, but it really ended up helping her confidence and just giving a space for sharing and validating and getting connected and knowing that we're all in this together, I think can be, because it's kind of like we're all siloed, all these clients and students are siloed and feeling alone, but they're all going through the same thing. So if we can get them communicating with each other, feeling a little bit more hopeful, I think that can help with the recovery process.
Hi, I'm Gab. I'm from FIT Health Services, and I'm a registered dietitian, and I'm part of the American College Health Association, and they have some free webinars, and I went to one, and it was really talking about Gen Z, and this was all pre-COVID numbers, so it's probably worse now, but pre-COVID in high school, all their studies and surveys, they found that students are interacting with each other less. So not only is it COVID, but this is Gen Z's normal social behavior. I know some of my work study students that are graduating this month, they're saying even their younger siblings, they didn't get their driver's license until they were 19 or 20 versus the previous generations, as soon as they could get their driver's license, they would get it. And I think part of it is too, it's like, why get a driver's license? Why go to my friend's house? We're just going to sit around and be on Instagram or Snapchat or social media. So I can actually just FaceTime my friend. So this is not, you know, COVID made it worse from all the surveys, but it's how they interact. And the hours that they spend with their friends versus going out with their parents, it's changed. Now they're spending less time with their friends and spending more time with their parents. They're not going in relationships, you know, they're not dating, they're not drinking. So as we're getting all these freshmen onto our campuses, even if they're remote, this is the lifestyle they've been doing. And so they're already coming depressed. They're already coming anxious. So we're just seeing it all falling down even more so because of COVID. So, you know, I think part of it is just giving yourself some credit and say, hey, this is just how the generation is. They prefer to be home. They prefer not to interact as much. So maybe not saying like you have to be interacting on this level that we've seen past generations, but I think, of course, some interaction is important. And with eating wise, with eating disorders, since I work at FIT, we get a lot of those. But luckily, I have had some students that are just on the cusp. And there's this new book that just came out this year. If you go on Google Books, you can see the first 70 pages for free. It's called Intuitive Eating for Every Day, 365 Daily Practices and Inspirations to Recovery from Rediscover the Pleasures of Eating. And again, this is not for someone who's just starting treatment, because part of intuitive eating, if you're not familiar, is you have to understand your hunger cues. So if your patient doesn't know what hunger cues are, this book could be a stepping stone. Where I like the beginning because it goes against like anti-diet culture. Like those are the first few weeks, and it gives you a daily practice. So it also depends on your client. Do they want that much support? Because sometimes it's like, wow, this is too much. I'm going to fail. I can't be perfect at this. And it makes them feel guilty. So some clients, I'll say, just look through the preview, do not buy this, you're not ready for it, and really hone down on it. Or there are some students that are on the cusp, they're listening to everything I'm doing. I'm like, hey, this will just add some more support because you get a daily practice, something to be more mindful. So it's just a great book. Too bad the chat, it seems like I can't just send it to everyone. But that's just something, again, it's a good resource that I've been using this year that's been helping out.
Thanks so much for that. I think that's an important perspective to have is, and it was actually in the back of my.
Oh, Amanda, we can't hear you that well.
You guys hear now?
A little better.
I think it's an important perspective to have. And I was thinking about it during the presentation. It's, there's no doubt sort of a crisis on college campuses when it comes to eating disorders, but what's going on in high school? What are we doing before they get to college campuses to help promote a healthy relationship with food and doing more preventative sort of mental health work before they even go to college campuses? And I think that we're not doing nearly enough. Our school system is so focused on academic performance, focused on social and emotional health and well-being, that young adults are going to college, they're prepared academically, like they're prepared to write papers and do well in their biology classes, but they're not prepared to deal with the social and emotional landscape there. And then often, whether it's food or substances, are turned to as a way to cope. So my question to Carrie or Dr. Coffin would be, if you, in your dream world, what would you propose that we do in high school and middle school to help ensure that young people are developing healthy coping skills and maybe preventing some of these problematic relationships with food?
I love that. I think that's such a great point, Amanda, of like, how can we get it a step ahead? I think that's a tough one, but ideally, I think it would be about trying to figure out better balance, right? I think a lot of the kids that are in high school right now just feel such tremendous pressure to get into the best college that they possibly can. They're hearing it as early as elementary school, the pressure to succeed. And I think the kids, the sophomores, the juniors, the seniors right now feels a little bit screwed because APs look different. Standardized testing is maybe not as important. And so some of these things that they've been banking on for years are also shifting. And I feel hopeful that maybe some of those shifts might ease up some of the pressure on some of the kids right now. But I oftentimes will talk about the importance of trying to find balance, the importance of trying to focus on the in-between. A lot of what you learn in high school and college is not just about your coursework, but it's about the friendships. It's about managing your schedule. It's about life skills. It's all those in between things that are also important. So how can we support our families to encourage that, the kids to learn that, and just as much, I think Gabby makes a great point about socializing, as much exposure to each other and to socializing as possible to get them to understand that piece.
Yeah, I think in an ideal world, I don't know how much of this is possible, but in addition to it starting, younger, like a lot happens within the families and at home. So if there were a way to engage parents and families more in schools, or like, in that process of education, psychoeducation in high school, middle school, elementary school, even, and also like emotional, there is more of this, but like emotional regulation tools being taught younger, I think is great. And it'll take time for that to kind of like show its results. But it's, eating disorders are like a communication issue a lot of the times, or an emotional regulation issue, a communication issue. So if we could get at the root of those things a little bit earlier, in families and in young aspects of school, I think that would be really awesome.
Carrie also talked about silver linings in her section. And I think one of the things that I'm sort of grateful for in terms of COVID is that there's really never been a better time for someone to take a step back and get the support if they need it. I think anyone on this call that's worked with eating disorders, it's so hard to get people into treatment because they never want to take time off from whatever they're doing. And I think there has been a bit of a blessing in the fact that everybody's a little wonky, everyone's schedule is a little bit off, the timeline might look a little bit different. So if you need to take a break, take a break. It's totally okay. You don't need to explain it to everyone. Most people are virtual these days anyway. And so I think there's been an advantage in that. And I'm interested to see what the fall will look like with that for our students. I know we're all anticipating everyone going back, but I think we'll have to buckle our seatbelts and manage that transition however it comes. But I hope that opportunity is still there for the folks we're working with.
Thank you guys so much for the presentation. Just wanted to let everybody know that we will be back here on the 20th for a roundtable with Cornerstones of Maine, and we're going to be talking about those very treatment-resistant clients and really focus in on MBT and psychodynamic interventions. So we hope you guys will all join us for that roundtable discussion as well. And thank you again, Dr. Coffin, Carrie, for doing this super helpful and informative.
Thank you, guys.
Thanks, guys. Have a good day.
Thank you.